So I wanted to talk about a subject that we do every day as an oral surgeon. Patients come in and we do grafting procedures several times a day between me and my partners, and we have a vast knowledge base on these procedures. So I just want to go through some topics, and we'll go through some cases later at the end, and then Greg from Straumann will talk about some Straumann parts and pieces as well. So save all your questions to the end. And thanks for spending your Wednesday evening with me. So to graft or not to graft? So, okay, I put this slide on. These are 3 places that I spent. Sometimes I have to think about it. I spent 14 years between these 3 different institutions. I did my undergrad at Penn State. And if anyone who knows me, there's a day that doesn't go by that I wear an article of Penn State clothing. So pretty much everybody knows I'm a big Penn State guy, and we actually had a big win this past weekend. So I'm in a very good mood. I spent 4 years at Stony Brook Dental School, and then I spent 6 years at Mount Sinai in the city, Upper East Side. This is actually the medical building right here. I actually spent 6 years there. It was a long road, but I would definitely do it again. So today, let's get into the lecture. So learning objectives, reasons why we bone graft. We're going to talk about some indications. Unfortunately, we had to talk a little science. I'll try to get through that part as painless as possible. We'll talk about different types of bone. We'll talk about when to graft and when not to graft. And I have some cases at the end that we'll look at. Let's move forward here. Indications, obviously, extraction sockets, fenestrations or dehiscence around teeth, to augment the posterior maxilla with sinus augmentations, and we also bone graft, obviously, for implants in terms of ridge augmentation as well. So these are some common indications that we do every day. So why do socket preservation? This is probably one of the most common things that we do as an oral surgeon. We take out teeth. We want to preserve the bone, not just for a future implant, but many times to protect the adjacent teeth as well. So I always tell patients that we do the bone graft to reduce the loss of bone that you have, to eventually have bone for an implant. And also, there's nothing worse when a patient comes back several months later or a year later and there's no bone to put an implant. So now you have to do a procedure to increase the bone. So we do this to reduce any additional surgery. So it's a known fact. You take a tooth out, you don't graft, we're going to lose volume of bone. And we lose mostly horizontal bone. You could see at 22%, and we lose vertical anywhere from 11 to 22%. So I took this picture out of one of the oral surgery textbooks, and this is actually this upside down, I call it upside down cone shape bone here. And this is what we usually see in the anterior maxilla when it's not grafted properly or not grafted, or the patient has been missing teeth for many years. So it's a known fact. You don't graft at the time of extraction, you're going to lose bone. It's going to make it harder down the road for any reconstruction. Also, factor in that all patients have different anatomy. Some patients have thin buccal bone, they have dehiscence or fenestrations around teeth, or they have thin biotype. So even when you take a tooth out and you don't graft it, some of these factors will inhibit or make it harder to graft down the road. So you also have to look at some factors dealing with your patient's anatomy when they present to you. So mechanism of bone formation. So we're going to get through some of the science here very rapidly. So we learned all these terms in dental school, in residency: osteogenesis, osteoinduction, osteoconduction. And a lot of the bone grafts that we use today have 1 or 2 of these properties. So osteoconduction is pretty much a scaffold, is where we need for bone growth to happen. So you need a material that the bone is going to lay down cells. So you need this property in your bone graft. and these are some common osteoconductive materials. So when I first trained in residency, we used a lot of bio-os. Bio-os was a hot material. It stayed around for many months. You saw it on x-rays. So we used a lot of bio-os, which is a xenograft material. Also, alloplastic material, calcium sulfate and beta tricalcium phosphate were common alloplastic materials that were used for many, many years. And they were osteoconductive. They formed like we said before, a scaffold or a landing for cells to form bone on. So these were very common materials. Osteoinduction. Okay, you need this. You need this to form the bone cells, need to come into play and to lay down bone. So you need those osteoblasts. So you need a bone grafting material that's going to promote osteoinduction. And pretty much common terminology, we need these osteoblasts to come into play. So the most common osteoinductive material, obviously, is autograft. It's your own bone, either from your mandible or maxilla. So that's the most common and predictable material. It's an autograft or an allograft. You can buy a cadaver bone, freeze-dried FDBA or DFDBA, and we'll get into this in the next few slides. So these are osteoinductive materials. For an autograft, these are common sites. A lot of times we obtain bone from patients, either from a maxillary tuberosity, a tori. A lot of times I'll take bone from the implant drills and mix it with an allograft and place into the grafted site. For big grafting procedures, we might take some ramus from the mandible, or even better, you might take extraction socket bone, septum bone, or some cancellous bone from the extraction socket. So allografts. So these are two different types on the market, either freeze-dried bone allograft or FDBA, or demineralized freeze-dried bone allograft, DFDBA. And I'll get into this in a few slides. So FDBA, this has an osteoconductive material. It's processed, it's cleaned, it's frozen. They process it and they put it down into fine particles. So this is FDBA. It's osteoconductive cadaver bone. And then you got decalcified freeze-dried bone, or DFDBA. This is osteoinductive. And they process it, clean it, get it all sterile. The big thing with this material is that it exposes BMPs, and this is very inductive property. Interestingly, I found this as well from DFDBAs, is that there is potential for disease transfer from cadaver bone from this material. So this common question gets asked every day in my office, and especially when this pandemic that just passed. Many patients say when they walk in, "Doc, I don't want cadaver bone." And you do your best to educate them. And I used to have a slide, and unfortunately I couldn't find it, that said 1 out of 30 million allograft cases there was disease transformation. But in the latest literature I looked up last night, I found this slide from the CDC that there was only 63 cases reported over the last 10 years. So if you think about it, my office alone would probably do thousands and thousands of bone graft procedures a day. Put that throughout the country, you're talking millions and millions. So if you only have 63, I know it still sounds like a large number. It's still very safe in my eyes. So I always tell patients that in myself, I would use cadaver bone, but obviously I don't do anything that a patient wouldn't want. So, everyone gets asked this question too, or this statement, "I don't want cadaver bone." So you have to know some substitutes to use that. So we'll get at that in the next few slides. This is a slide I took from Straumann. This is one of their common products. They use a mineralized, demineralized mixture, an 80-20. And if you notice, and we'll talk about this throughout this common concept throughout this lecture, is that we mix a lot of grafting materials. We try to get different properties from each one to give its best probability or predictability of working. So you can see in this mineralized cortical, it's a great space maintainer, or a scaffold. And then you can see the demineralized cortical bone has its osteoinductive properties. So they mix both of them together and they get a very predictable grafting material. And there was one of the studies, this is just a study slide I got from Jurman as well. And pretty much, if you look in the bottom line, conclusion, more bone formation was better when you mixed both the mineralized and demineralized together than just FDBA alone. So the concept is, if you mix, you get both key properties of different bone grafting materials. Interesting, as I was going through some of the material, and you have to know where your bone grafting material comes from. I was looking at this a little research that there's over 150 tissue banks in this country alone. Only 100 are accredited, and most of them, the 100, are accredited by the AATB, which is a nonprofit institution. They screen patients. They have a standard of processing bone grafting material and where they get it. And so they're the premier accredited bone bank. So, it pays to know where your grafting material comes from. I mean, interestingly, a few years back, before we used the Jurman product, we definitely used a material that we deemed wasn't an ideal product. Anytime we went into the grafting socket, the bone wasn't what we wanted. So that's why we made the switch. And it turned out that the bone grafting material was from a non-AATB bone bank, which was interesting. That's why I put this slide in. Bone regeneration. Obviously, we're trying to regenerate bone. In the next few slides, we'll talk about, when you generate bone, you need space for the new bone to form. So either you use a membrane, or you use something to create space so the soft tissue doesn't disallow bone from forming, or connective tissue to grow into the bone process itself. So a lot of times, whenever we're doing any grafting procedure, I usually throw down a collagen membrane to either retain the bone particulate and also to prevent any soft tissue ingrowth. Also, sometimes if I need more width, I might use a tack to hold the membrane down, and this is a common biohorizing tacking gun that we use. Or sometimes I'll use some tenting screws to tent up the soft tissue to allow some thickness and width of bone to form. So that's where I get the concept of bone regeneration. Also, you need some growth factors that help with bone regeneration. So in our office, we definitely, in some cases, we might spin down some patient's blood and make PRP. We have a PRP machine here for the last several years. We have the advantage of, when we put patients to sleep, we take some blood, we mix it down, and we take some of the PRP, which is a great growth factor that forms nice membranes. We actually secrete some of the growth factors over the graft itself. It forms a nice thickened material, which is easily to handle for the grafting material. So it's a nice product that we have in this office. Jurman has Emdogain that a lot of doctors use, promotes PDL growth and connective tissue growth. And there's some products, Gem 21, one or two of my partners like to use and mix it with some allograft material. And through my career, I also use some BMP infused product that shows excellent results with grafting as well. So it's always good to have some growth factors on top of the allograft material or autograft material. I put this slide in because we all will come across through our career some x-rays that have either alloplastic material from post-extraction sockets or grafting areas that show up very radiopeg on x-rays. And this is usually the hydroxyapatite. This is a non-absorbable material. Like I said, it comes up very radiopeg on x-rays. Actually, sometimes looks like there might be a root still left behind on a pan or peri. These were very common materials used in the late 90s and early 2000s, especially your calcium sulfates and your beta tricalcium phosphate. I typically don't use alloplastic materials. Sometimes when patients don't want allograft, or I can't take their own bone, or they don't want xenograft, the animal. Sometimes I will use an alloplastic material. So it's always good to have it in the office if you do some grafting material, grafting in your office. I put this slide in because this is our common referral card, and a lot of referring specialists have something very similar. And as the referring or restorative doctor, if you ever send a patient for extraction, one of the key things that I've noticed is if you tell the patient, or you write it on the card, please bone graft, or prepare for implant, or socket preservation, or graft, the patient comes to our office or the specialist knowing that it's something that they need, or something recommended by you, their dentist, someone who they trust. So when they come to the specialist, they know that's what they need. So it's more of accepted treatment than me saying to the patient, oh, when you take the tooth out, we have to graft it to build up the bone. It's a lower case acceptance by the patient. So it's always great, really, it's really nice to see when the patient already requests the grafting procedure. So please, if you ever refer, if you could write that or explain that to the patient, that helps out on our end. So let's get into some cases here. So this patient here, he had tooth number 31 extracted. He did not want it grafted. Came back 4 months later, said he definitely wanted to do an implant. It doesn't feel like his chewing is even on both sides. And when you take the cone beam, which we usually do in the office here, you could definitely notice that the buccal plate didn't come back the way we would like it to. The patient generates some bone, but he definitely has definitely lack the width that we would like. And it definitely is going to affect the implant placement to get into a better spot for more bone. So it would have been definitely a better situation if the patient let us graft it when we took the tooth out. So this is a common procedure that we see every day in the office. Take out hopeless number 14, graft it. We use a mixture of a cortical cancellous mixture from Jurman. We find we get great results with it. It's great space maintenance and also inductive properties. And you can see 3 months later, you have excellent bone fill in this area. And this is the product from Jurman that we use. Like I said before, is a cortical cancellous mixture. It comes in 2 cc's. We don't use 2 cc's for every extraction, but I'll show you later on how we prepare the bone graft. This is another case that we did in the office, and you could see the patient had teeth extracted just about a year ago. And you can see that she definitely doesn't have enough bone here to replace 13 and 14. So now she needs a sinus lift procedure, which is fine. We do them all the time, but maybe if she had the grafting done when she had the teeth out, she might not need the sinus lift. So we did the sinus lift procedure. You could see here on the bottom screen, the cone beam here, she had good fill of bone. You can see it here as well. And we're able to put 2 implants in after the sinus lift was performed. Sometimes even when we do a grafting procedure, especially for the posterior molars, patients always are like, oh, you grafted at the time you took the tooth out. But unfortunately, due to the patient's anatomy, we still need to add some bone. So sometimes we have to do internal lifts. And a lot of times, the time we do the implant, we could do the internal lift to add some bone. And usually we do that when we do the osteotomies. And you can see here for tooth number 3, the patient had about 5-6 millimeters of bone, and we did an internal lift to get a 10 millimeter implant in. And like I said before, a lot of times when we do our implants, we take bone from the implant, we mix it with the allograft, and we'll add it around implants. A lot of times I do a lot of immediate implants. So a lot of times I'll take this mixture and actually put it in and around where I put the implant in. So usually we save a lot of the patient's own bone and mix it. This is another example of a patient who had to get tooth number 4 extracted. I'm sorry, tooth number 5. She was missing 4 for some time. You can see the deficiency in bone here. But the reason I put this slide is that we're able to take out tooth number 5. We grafted that, and we also did a sinus lift at the same time. And you can see on the CBCT, sorry for my funky red lines here, but you can see we have good width of bone and good height. And you can see how the sinus lift came out as well, and we're able to put 2 fixtures in. And usually we wait about 4 to 6 months to put our implants in after our grafting is done, especially for sinus lift procedures. Again, just showing some common theme here. Took out tooth number 4, grafted at the same time. And again, you can see here we waited about 3 months. When I do a single tooth extraction with grafting, I usually see the patient back a week later, and then I set them up for a 3-month follow-up with a cone beam. I tell them come back in 3 months. I say usually it takes about 12 weeks for the bone to form. They come back, it would take 3 to 4 months, and take the cone beam, and then we set them up for an implant. Majority of the time, the patients would like to do the implant that day when they come back at that 12-week or 3-month follow-up, but that's our routine in the office. So this is the reason I like to put this slide in is that when I first did a lot of grafting early in my career, it was always it was hard to handle some of the material, especially the particle bone. It would never get into the extraction socket. It would fall onto the patient's tongue. You would miss it, go down their throat, whatever the case was. So now what we do is that we get these 1 cc TB syringes. We take some bone grafting material, the Jurman product, we pack it into the TB syringe. We hydrate it, we cut the tip off, and then we have an easily delivery system into the extraction socket. It works very well, depending on which tooth. Sometimes I'll tell the staff to give me up to 5. Sometimes I tell them to give me a full CC. If we're doing a sinus lift, a bilateral sinus lift, maybe they'll make 2 or 3 syringes for me. But it's a really great tool to have when we're doing a lot of socket preservation or even sinus lifts. And this is a patient I just did a week ago. Sorry for my photography, but usually our technique is we take the tooth out, we clean out the socket, we deliver the mixture of bone with the syringe I just showed you. We packed it in. I usually cut off a piece of membrane, lay it in, 2 dissolvable chromic sutures, and then I'm probably 1 or 2 of the only ones in my practice, but I still use this, I call it bone glue for short, but it's a periaqual type of glue, and it just keeps everything nice and tight, I call it, or sealed off. Nothing worse when the patient comes back a week later and goes, "Doc, the whole graft fell out," or is anything left in the socket? So I rarely get that complaint anymore, but I find it very useful, this periaculate or bone glue, I like to call it. Again, a common technique in the office, extract, you see we did the extraction here, we grafted, get a 3-month follow-up. Again, very nice bone fill, looks great on the x-ray, patient's ready for the implant. So again, we talked about some patients don't want to use cadaver bone, but in this patient, it was fine using, he came and told me, "Cow bone is fine, doc." So one of the reasons I don't like to use xenograft by itself especially is that it just doesn't get you the results that we get with allografts. And you can see here, this was about 4 months after extraction socket. You can see there's not much bone. And you can see the radiolucency or the darkness on the x-ray. So I had to go back and regraft it for the patient. And again, still, he didn't want any allograft or cadaver bone. So he asked me to use his xenograft again. So this time I definitely wanted to try something a little bit different. So I mixed in some calcium sulfate with the xenograft as well. And the xenografts, again, they were very popular for many years. A lot of times we used them when we were doing sinus lifts, so we mixed them with some allograft. It looked great on X-ray because it came out very radio opaque. Stayed around for a very long time. So at one point, xenograft, or BioOS was very popular. And one of the reasons I felt it was very popular too was very easy to handle. It came in syringes, came in putties, came in pastes, so it was very easy to handle. But again, I rarely use a xenograft unless a patient definitely doesn't want to use cadaver bone. So let's do some cases here. So I'm going to touch on some themes. I think this is where dentistry is heading, is we're going to see patients who had implants placed either recently or 10, 15, 20 years ago, and they're going to come in with bone loss around the implants, and we're going to have to come up with treatment plans to incorporate bone grafting techniques. And most importantly, patients do not want to wear anything removable. So we have to think out of the box and try to come up with solutions here. So for this patient, obviously she was losing this anterior bridge here. You can see how the the defect affected adjacent teeth, so they had to come out as well. So the treatment plan was remove the implants, graft area. Patient will have a temporary on the remaining 3 teeth that we're going to keep until the graft heals. So in her case, we removed everything. We bone grafted with allograft. She actually also had PRP done, where we laid the membranes over the graft. But the key in this case, and I want to touch on it, is that she didn't wear anything removable. There was no pressure or tension on the graft. It was able to heal because we kept a few teeth, and she wore this lab fabricated temp, and she was very happy with it. And this is 4 months later, and you can see you have very good bone fill. I'm probably going to give it another month or so, or it's another 6 weeks. Again, she was very happy with the temp. You can see in the bottom slides here that she's starting to get good width. She has good height. Obviously, there's no nerve in this area as well. Again, my funky red lines, I showed that she had good width and good height. So she's going to have a good result. We'll put some fixtures in. After we put the fixtures in and we know they're integrated, then we'll extract the remaining teeth, and then she'll get a fixed implant supported prosthesis. So this goes into when not to graft. So unfortunately, one of the hardest areas to graft is the posterior mandible for 2 reasons. A, it's very hard to grow bone back there, especially height and width. And number 2, you're dealing with a nerve. And you can see on this patient, on these cross sections, this is where her nerve is. So it's almost impossible without removing her nerve or transplanting her nerve to do any grafting procedure here. So when patients come in with this request of can you graft back here, it almost should be, what can you do? I know you can't graft back here. So one of the concepts that we develop, and I'll show in the next slide, because again, I see this case all the time. There's another patient in the posterior left mandible here. You can see there's her nerve. You can see how very thin the bone is. I mean, to put a patient through a grafting procedure with screws and blocks of bone and PRP, you're talking months. And then the whole thing is you can't wear anything on the graft as well. It's a very difficult surgery to perform with success. And my key is predictability. So what I would recommend, and this is what I recommended for the last patient, is traditional all-on-4. Most patients have good bone between the foramens or sufficient enough bone, and you can cantilever some posterior teeth. Obviously, you can see here's her foramens on both sides. We avoid any grafting back here. So this is a better alternative than a posterior grafting to the mandible left or right. So when I said not to graft, we should have this treatment option ready to go for patients. Okay, a few more cases and we'll be finished. So this was a case, interestingly, this young man who was actually 18 years old. He got fell into a train and hit by a train. I think the exact when it came first, but he lost his front teeth. He was sutured up at Bellevue Hospital, and then he came out to us about 3 weeks later. And this is what he looked like. You can see his soft tissue has pretty much healed up, but you can see in these x-rays he has no bone. You can see how very thin, there's no buccal cortex, and you can see on the reconstruction that there's very or no buccal plate intact. So you can still do what I call delayed grafting. Get this patient in, open it up, and put some grafting in. And we put an allograft in, we put our Straumann mixture in. This is a picture of us opening up the site. You can see he still has the extraction sockets. He has some buccal wall still intact. And this is him 4 months post-op. And you can see he had a very good result. And there was 2 reasons why he had a good result. Besides, he still had some buccal plate intact. The key is that he didn't wear anything on this. He didn't put any tension on this. He didn't wear a flipper on it. He didn't wear a partial on it. The dentist made him an Essex that was supported by the posterior teeth. So there was no pressure on the wound. So it was able to heal. And now he's actually going to, he's going to be getting implants in the next few weeks. So again, not to graft. So unfortunately, this 72-year-old male came in, wanted some implants done. He was told by his dentist come in for an implant consult. But you could see from this CBCT and from the pan, he has no bone in the posterior area, very thin bone on both sides. And this is the cross section. I'm sorry, this is the coronal view on the CBCT. You can see how very thin the bone is back here. Very hard to do science lifts back here and get good bone to get some fixtures in. But most importantly is that look at the anterior area here. Very thin. So in this case, and the patient did not want to wear, he wanted nothing removable, wanted all his teeth out, wanted a solution right away. So we're recommending zygomatic implants for him. It's the only solution I deem necessary for this patient at this point. I think it's our last case here. There's a young man that was born in Central America. He actually had several teeth extracted at a young age. And this is a cross section of what the bone looked like. You can see this concavity that he had. You can see he was missing from canine to canine. You can see when you opened it up, again, these buccal concavities that he had. He had very thin bone. And again, he wanted a fixed solution as well. So we plan to do, in this case, he definitely need a block reconstruction. So we got these block grafts, actually Puro Zimmer block grafts. And you could see how they went right into that concavity of bone that was up here. We placed 2 with contoured the grafts. We fixated them with fixation screws. We actually put PRP membranes over, and we actually put particular bone over as well. You can see in this slide, this shows the spin blood. This shows the membranes. This is all PRP, by the way. Sorry. And you can see how we put the membranes over the blocks. You can see some of the particular bone, and you can see how we got a nice closure here. And this is one of the other concepts I want to touch. If you don't have good connective tissue closure over any graft, it's not going to work. So you definitely need a nice closure, nice soft tissue closure, and you need no tension on that wound for that graft to take. So after about 4 months, the dentist, restorative doctor, did a wax up for us. Did a wax up and then made a scanning prosthesis for us. You can see the scanning markers. He went to our CBCT. We actually planned this case guided. Yes, one of the reasons you could see here, we had to open the wound up again. I know a lot of times we do guided cases, we don't have to do it. We don't have to open up the connective tissue or soft tissue. But in this case, if you remember, he has these fixation screws in. So we had to remove the fixation screws. We put the guide on top. We put the implants in. You can see the osteotomies in the screen over here. And you can see 4 months later, we did uncovering. We did stage 2. We put healing caps on. Again, the reason why this worked for this patient is that we always had a good connective tissue or soft tissue closure. And number two is he wore an Essex appliance as well. He had no pressure on the wound. So everything was able to heal very well. I'm going to leave the next 5 slides to Greg, and then we'll do one last slide to end the lecture. Greg?
Yeah, thanks, Dr. Jurman. So I just wanted to address and kind of review a few things with some of the restorative parts and pieces when it pertains to the BLX implant and then the BLT implant. I know I've spoken to a lot of you, but also I do still get a lot of questions when it comes to this. So this is a really good little chart just showing that for BLX, there are two platforms here, and that is the RB regular base and the WB wide base platforms. And what's nice about the BLX is that the open tray impression copings or the closed tray impression copings can be the same across all platforms because it's one internal connection for this implant. They do have it separated out if you needed to for color coordination. That's kind of the big key with the Straumann parts and pieces, that everything kind of goes together with its platform and also with its colors. But you know, RB can stay on RB or WB. WB does have to be for WB only. So in a pinch, if you ever had a WB implant come through and for the restoration you needed to take the impression and you had an RB impression coping, you could use that. Always just like to keep in mind just to make sure your lab is aware that even though it's a purple coloring for the RB and it's used on a WB implant, that it is a WB implant that is what's being restored. So again, this is the BLX implant. And again, the colors here are purple for the RB and then brown, which would be for the WB. And then there is, again, digital impressions. We have our scan bodies, and there is only one scan body for BLX. So that does make it simple as well. So a little bit easier to ease of use when you consider the different platforms, but all the real components can be used across all the different connections. So that's the BLX. And then I can't advance the slide, so I don't know. Oh wait, there we go. This here, similar type flow chart. Again, similar color coordination. This is for the bone level and the bone level tapered implant. And this is where we have the 2.9, which is the blue, and that's your SC, that's your small CrossFit. Your yellow, which is your 3.3 diameter implant, that's your NC, that's your narrow CrossFit. And then the 4.1 and the 4.8 fall within the regular CrossFit platform. And blue for the 2.9, yellow for the 3.3, purple for the 4.1 and the 4.8. Here, parts again, everything matches accordingly. So it makes it easy to kind of cross-reference. And a lot of the different questions I have seen in the past is when doctor asked me for a BLT component for a 3.3 implant, and then they receive the closed tray impression or whatever impression they're ordering, and they say, hey, I was looking for a BLT. This one says NC on it. So the NC, RC, SC here is pertaining to the bone level and the bone level tapered implants. It's going to go off of the connection. It's not going to go off of the name of the implant itself. So again, all these different diameters do have scan bodies as well. Scan bodies here are specific to the implant for the SC, NC, and RC. And again, same with the impression copings themselves. This is for the bone level tapered implants, and these kind of go over just again showing that the closure caps are again color coordinated in the blue, yellow, and purple coloring, and then your healing abutments, again, same thing. So you have your variety of different healing abutments that will be used on the implants, and they are also color coordinated to match up to the connection of the implant size diameter. So makes it very easy So if you're a color person, if you're a visual person that way, this is a very helpful to kind of keep everything, to know what you're using on what diameter implant and what goes with what, with the impression copings and taking your impressions. This will just kind of review our portfolio of what Straumann has on its implant portfolio. Something as small as a 2.4 millimeter implant, which is our ridge fit implant there. That's a one-piece implant, but again, 2.4 for limited space when there's limited bone there. Our short implant, we have a 4 millimeter length implant that is on a tissue level platform. So for space needed, the 4 millimeter is really useful when you have limited height. So that's your 4 millimeter. We have our 2.9, which we kind of just talked about a little bit with our BLT. So again, your standard implant, not the one piece like the 2.4, but your 2.9 is a smaller diameter implant there. And then with our BLX implant, you can get as wide as a 6.5. So a lot of different capabilities and a lot of different options for whatever the case is calling for. There's kind of a solution that will fit those needs. So I think this is something that is useful to kind of see that there's a variety of different options within the Straumann portfolio for a variety of different patients that are going to come in with a variety of different needs. And there's something to kind of fit that, whatever that need is. So, and I think there might be one or two more, but so this is a little bit to piggyback off of the BLT healing abutment slide that we were just showing. This will show you how the BLX, this is the BLX healing abutments, have your purple and brown coloring, but again, you have RB and WB platforms, and the RB, WB can be used across the full platform of diameters of the implants, because again, it does have that same internal connection. WBs cannot go backwards or down, so to speak, or you can't use WB on an RB, but the RB, WBs can be used kind of as you need, or wherever that flexibility gives you. And this gives you a little bit more variety in terms of how these abutments are measured. The column all the way, well, not all the way to the left, third from the left gives you a kind of a total height. So for example, on an RBWB abutment, a 4.0 abutment, highlighted kind of in yellow, it will kind of break it down to give you a gingival height, option of height, and an abutment height. So really it's a 4.0 by 4.5 healing abutment. You can use that same healing abutment, but at an abutment height of 4 and really make it, it'll kind of be a 4 by 6.5. So really, really wide variety of choices with this BLX implant. And being that there's a wide variety of different sizes within the BLX platform, the wide variety of different healing abutments really makes that flexibility, gives you the option for more flexibility than there ever was before. So this is just kind of an overview of some of those different types of healing abutments. But again, theme here, colors, matching. So it simplifies a little bit to kind of know what you're looking at when you're looking at it, what implant it could be if you don't have the information in front of you. Or if we discuss anything, we can kind of troubleshoot or go over any details, just based on color. Or if there's not much information on the size of the implant that was placed and it just is indicated for any of the connections, again, that could say SC, NC, RC, or it could be RBWB, we can kind of, together figure out that it could be a BLT implant or a BLX implant, and then, get all the necessary parts and pieces for you for the restoration. So just a little bit more, just just a little bit easier way to simplify everything. And some of these slides that we reviewed, I know I have reviewed with a lot of you here on the call. I know you have a lot of you have them in the offices. But if anybody doesn't have them or wants them or needs them or would like them, please let me know, and I'd be happy to review it with you in person, or just have it so you have it in your office as like a little bit of a reference or a cheat sheet, so to speak, just to simplify and keep track of everything in its necessary place. BLT, BLX, how do you know? This is how you know. So
one additional note to add on that, Greg, is just this is Keith. Hopefully you guys can hear me okay, but this what's nice about the BLX system, and again, why there's so many options here, is these actually mirror the final restorations. So your prosthetic abutments that you might design, you can get in a healing abutment that will match your final restoration. So you have a lot of flexibility here to help kind of create the emergence you're looking for. And if it's a shallow implant, you don't have a lot of tissue, you can use a very shallow healing abutment that also flares out and gives you a good emergence profile. So there's a lot of flexibility in this, and you can almost use these as like a tissue former and a custom tissue former that will match your final healing abutment. So I know it's a busy chart with a lot of numbers on there, but just know that the flexibility will link up and match your prosthetics you get from Straumann exactly. So you can create the same emergence from the time of healing all the way through to final. So that's kind of the key with this and why there are so many. So there's a few, molar immediate of choice, premolar and canine immediate of choice. So speak with Dave, speak with the team at Leading Edge, and they can say, this is what we have here. This is the tissue height. It's a molar region. Let's put in a wide, short healing abutment, and that's going to match your final. So that's just a nice feature of it. Just wanted to add that in, but thank you, Greg.
Thanks, Keith. Thanks, Greg. I think you guys can hear me still, right?
yeah, we can still hear you. I actually think there was one more slide, which I kind of reviewed on some of the others. There's just for digital purposes, for digital scanning, intraoral scanning, this is kind of a review kind of showing the different implants and what scan bodies go with it. So again, like I was talking about with the BLX implant, there's kind of one scan body regardless. The BLT does have it specific to the size of the implant, SC, NC, and RC, and our tissue level also has its own scan bodies too. So anybody that is out there scanning, we have scan bodies for any of those implants, and anybody who is not scanning and is looking to do digital scanning, this would be how you would be doing your impressions, and these would insert into the implant, and you do your intraoral scan, and you'd be done. And the patient is less invasive and just an easier way to take those impressions. So there's these options as well. I think we did have a question come in on one of the
there was
chat.
I could read it for you, Greg, if you like. So the question was, and I answered it in the chat, but it was, what is the necessity of using a plastic cover for the impression coping? And the answer's in the chat, but I know it's different than a lot of systems. And, a lot of times we provide two just in case one gets dropped. It's kind of an FDA regulation why we don't sell them separate, because it's a single-use item. But what it provides is anti-rotation, and it provides a more rigid platform for the closed tray impression to snap into. So, we don't have any data or science to support it, but a lot of times you'll hear people say, the closed tray with our system, because of that plastic cap that's locked into the material, you don't just rely on the impression material there. So if you're using a medium body or a heavy body and a light body wash, the impression coping will snap in, lock into that material. Your lab can seat that coping into the material, or you can do it before you send it over, and it's not going to allow for any rotation. It's not going to allow for any distortion of the material, and just provide a better fitting final restoration. So that's why we do it. That's why we developed that cap. Now, if you were to say, well, I'm not going to use it, I'm out of them, you still have a rectangle impression coping, You still have anti-rotation built into that, and you still have, depth built into that. So I would say, without the cap, it's as accurate as any other system. I think with the cap, it's more accurate. It just speaks to, the design that Straumann kind of puts into their product. So hope that answers the question. We don't sell them separately. I get that question a lot too, just because, FDA says it's a one-time use product, although it does get reused. So we provide two in case you drop one. But again, happy to work with the group here and Leading Edge to, provide some parts if something's needed, something comes up. So hope that answers the question. I don't know if there's another one there. Greg, I didn't see another question, but.
No, I think that was the one. And yeah, I think that's the answer. I can't really piggyback off that too much more. That's
one thing I
that
like
is
to add is
easy.
that at our leading edge offices, we do have scanners in all the offices. So if there's any reason you need us to scan the patient for you, I've done that for many restorative docs for numerous reasons. We have all our assistants know how to scan, and would be happy to help you with that too. So just to leave you with that thought. Okay, so the last slide is just to end the lecture. Let me see here. I just want to thank everybody again. I'm a big Penn State guy. I also played lacrosse there. I don't know if anyone knows that either. Hold on one sec. Let me start my video. Okay. And again, sum up the lecture is that, we don't want to put patients through procedures that have low predictability, because I feel like in today's age, patients have high expectations. They pay a lot of money for these procedures. So we definitely want to do things that we know will work. And there's definitely alternatives. So anytime you send over a case, any of my partners in the office will sit down, we'll go over with you before we present it to the patient, or we can all do it together. So just want to sum up that way. I just want to thank everyone again for being on the lecture. Thank Angelina, Greg, Keith, and all my partners here at Leading Edge.